right, hi everybody. We are so glad that you joined us in person today. We know that there's a lot more online too, so hi guys. We'll briefly introduce ourselves and then we'll get started with our cases. We chose these cases as pretty common cases that we all encounter either in academic and community practice, but in some ways we as medical oncologists have been thrust into new spaces because of new drug approvals, so we chose those cases intentionally, and so we hope that this is high yield for everybody, and it sounds like questions will be at the end, and we'll be happy to take any that you have. So I'm Jackie Brown, and I am an assistant professor in the Department of Medical Oncology at Emory.
Hi, my name is Vishal Dhere. I'm a radiation oncologist. I'm also an assistant professor at Emory University. I treat primarily prostate and bladder cancer.
Good morning, everybody. I'm Vikram Narayan. I'm also an assistant professor at Emory. I'm a urologic oncologist, and I treat mostly bladder cancer, but also prostate cancer and kidney cancer and testicular cancer as well, and the occasional penile cancer.
I do mostly bladder and prostate, like Vishal. All right, so we'll just kick it off with our first case. So this is a case of recurrent high-risk non-muscle invasive bladder cancer, which, to my point earlier, medical oncologists are new to this space, but there's reason for us to try to get oriented with many of the new approvals here. So Gary's a 75-year-old guy. He experienced months of intermittent hematuria. He was referred to urology. Ultimately, this workup led to a CT urogram. This showed a 2.6 centimeter mass in the bladder. He had no evidence of metastatic spread to lymph nodes or further on that image. And the pathology from his transurethral resection showed high-grade urothelial carcinoma invading into the lamina propria, or T1 disease. He received a sufficient induction course of BCG, followed by maintenance BCG. On repeat assessment, he had recurrent high-grade T1 disease, and this urothelial carcinoma had 10% micropapillary differentiation, and he returns to clinic to discuss his treatment options. And to be clear, the clinic he's returning to is Vikram. So I have a couple questions. One is, how does the presence of variant histology in him, but in general, impact decision-making? And then what defines high-risk disease in non-muscle invasive bladder cancer?
Yeah, so Jackie, when I see this patient in clinic, obviously there are a couple things that come to mind. First, the fact that he has T1 high-grade disease, which of course is defined as invasive into the lamina propria. Now, generally speaking, we all know that we draw a line between non-muscle invasive and muscle invasive bladder cancer, with muscle invasive bladder cancer being defined as T2. But the reality is large volume T1 disease in many cases can be just as aggressive, if not lethal, when compared to T2 disease, and this has been demonstrated. And so when a patient presents with large volume T1 disease, which I define as greater than 5 centimeters in size, or when they have the present of variant histology, in this patient there was a component of micropapillary disease noted, those are patients that I think are worth having a discussion for upfront cystectomy. Now, the reality, of course, and this slide here shows kind of the different components of histologic staging, and the two things that you've highlighted show CIS and T1 as potentially being high risk, and I agree with that. So these are patients, if the patient has a presence of CIS, has large volume T1 disease, or any presence of variant histology, all of those patients are classified as high risk. Now, one of the things that we discuss with patients up front is I think it's useful, even though the mainstay of non-muscle invasive bladder cancer is intravesical therapy, which we'll talk about, specifically BCG. The mainstay of the reason we use BCG and other intravesical agents is to prevent cystectomy or to avoid cystectomy. However, if a patient ends up recurring or becomes BCG unresponsive, then that patient is at much higher risk for developing metastatic disease. So in terms of kind of how I would counsel Gary, the first thing I would talk about is potentially doing a restaging TURBT, because up to a third of patients who have a second TURBT can actually be upstaged to muscle-invasive bladder cancer. So that would be the first thing. One of the questions on this slide talks about asks what defines BCG failure. So there are actually a number of different definitions of BCG failure, and this is partly what has led, unfortunately, to a lot of confusion and changes in or kind of variability in practice pattern. Recently, and this is now about 5 or so years old, there has been emerged a definition of BCG failure. Specifically, we call it BCG unresponsive disease. And someone who's BCG unresponsive is defined as someone who has received what we call adequate BCG. So adequate BCG is what we call the 5+2 rule. So just as a reminder, anyone getting BCG, an induction course of BCG is 6 doses of BCG given 1 week apart. And not all patients complete all 6 doses because of intolerability, et cetera. So if somebody gets 5 out of 6 of an induction course, plus 2 out of 3 of a maintenance course, so maintenance BCG is once a week for 3 weeks, or a second induction course and they get 2 out of 6 of that second, so 5+2, they've gotten enough BCG such that if they recur thereafter, usually within a 12-month period, they're defined as being BCG unresponsive. And this definition is important because it drives a lot of the trials, and we're going to talk about some of the trials that have emerged in this space. But cystectomy does remain gold standard and is always offered as kind of the first option for people with BCG unresponsive disease. That being said, many patients don't want to have their bladder removed or are medically unfit to have their bladder removed, and so we talk about other treatment options with them. So,
go
ahead. I was just going to say, so the reason it's gold standard is because we have, an 80 to 90% complete response rate at 3 years, which, as you'll see over the course of this talk, is probably the best outcomes you have, unfortunately, for even if you compare some of the other treatment options that have emerged.
Okay, so as someone's in your clinic and you are counseling them, what aspects of their disease, and you touched on this kind of tangentially, but what aspects of their disease and clinical features would make you really try to guide them towards cystectomy rather than one of the other options we're going to talk about next?
Yeah, so I usually look at the op note, and especially because a lot of these patients get referred from other centers, and I'll say, okay, did the other urologist comment on how much of the disease was resected? So sometimes they'll say there was an incomplete resection or only partial resection. So that kind of gives me a clue that, usually if a urologist is only partially resecting tumor, it means that they felt that there was too much tumor to safely resect completely. Most of those people I will take for a resection myself to see if that is in fact true, but that's one big feature. Another is the presence of hydronephrosis. So presence of hydronephrosis, even if the pathology only shows T1 disease, suggests T2 or clinically stage T3 disease typically. And then finally, the presence of variant histology are all reasons for upfront cystectomy.
And then, again, you mentioned that patients may be unwilling to pursue cystectomy, even if recommended, or unfit for cystectomy. What is the patient experience that you encounter in clinic when you're having this discussion?
Yeah, so, to be clear, when somebody's bladder is removed, it really is a life-changing kind of journey that they then embark. And part of that is because when a bladder is removed, you have to create some kind of urinary diversion for them, whether that comes in the form of an ileal conduit, where they wear a bag for the rest of their life, or continent diversions, such as catheterizable channels or a neobladder. All of those options require a complete and fundamental change in kind of one's daily routine. So everybody in this room, typically does not think about their urinary symptoms on a day-to-day or minute-to-minute basis. We take it for granted. But when you have your bladder removed, that becomes a life-changing experience. And so being thoughtful about, how to approach that with patients, setting expectations. Many patients are reticent to have their bladder removed, and for some it comes as a surprise because when you're first diagnosed with non-muscle invasive bladder cancer, and that usually is about 80% of all bladder cancer diagnoses, usually doctors tell folks like, look, listen, we'll give you some medication in your bladder, we'll do these resections, and you'll be fine. So when they develop BCG unresponsive disease, it's a big surprise when suddenly you're flipping gears and saying, actually, you need to remove your bladder. So I think setting expectations, connecting patients with others with similar conditions, and referring them to support groups such as BCAN is extremely important to help manage their course.
So we're going to get into a little bit, let's say that this person declines cystectomy in this setting, and so we want to talk to Gary about what his options are. We're going to spend the next couple slides talking about the FDA-approved options, which include intravesical chemotherapy, pembrolizumab, and most recently, nadofaragene firadenovec, which Vikram will tell us more about. And we'll briefly talk about some exciting clinical trials in this space because of how their efficacy may stack up to what we have FDA approved right now. And I put the picture on the right just to remind me that, I think, and I haven't been a medical oncologist for 40 years, but I think before this was very much the lane of urology. And we really only got involved in patients' care when the disease became muscle invasive. So since we are the primary operators within this list of pembrolizumab in the FDA-approved options, and certainly there are many systemic agents being studied in clinical trials, it's pretty important that we have a general understanding of what the landscape is, because if someone's coming to our clinic because their urologist referred them to talk about 2 years of pembrolizumab in this space, we want to understand what their alternatives are.
So one of the things that is worth mentioning is that the FDA has approved valrubicin, and this was back now over 20 years ago, for the management of what they called at the time BCG failure. Now, if you actually go back to the original study, only about 70% of the patients in that trial met the modern definition of BCG unresponsive disease, but subsequent analyses have shown that valrubicin is, despite being FDA approved, relatively low in terms of efficacy, with a complete response rate of only 10% at 1 year. But this is still an important treatment to keep in mind because it sets a benchmark of what all other modern treatments that are currently either being investigated or have been approved are compared against. Obviously, it's a low bar. It does not compare to cystectomy, but in terms of intravesical salvage agents, the kind of the threshold to sort of beat is this 10% complete response rate at 1 year. Now that is changing, particularly in the last 6 months to a year, as we've now had several newer agents. There's discussion about should that threshold be raised? Should we be doing something more than single arm trials, which personally I think we should. There is more complexity there, but this is something to just keep in mind. In practice, I don't prescribe valrubicin to any patient with BCG unresponsive disease because of its low efficacy.
Okay, so we touched on pembrolizumab, but I just want to share the data to support this FDA approval. So this all stems from Keynote 057, and this was a single arm, one of those single arm trials, open label phase 2 studies. And this was for patients who had high risk non-muscle invasive bladder cancer that was unresponsive to BCG, who are either A, refusing, or B, ineligible for cystectomy. Now, Vikram, I do want to lean on you to help us as medical oncologists and medical oncology teams understand why cohorts A and B exist. Because suddenly we've got a drug that we need to use, and this really stems from a deep understanding of non-muscle invasive bladder cancer.
Yeah, so there's kind of two things to understand. The first is, why is this a single-arm study? So, most of us don't expect FDA approval from single-arm studies, but the thought process here is, if you have someone with BCG unresponsive bladder cancer, the option is either radical cystectomy or some intravesical, or in this case, systemic agent. But as we all can imagine, it is almost impossible to randomize to such a choice because a cystectomy is a hugely invasive and morbid operation, and then you're comparing to an agent that has potentially less morbidity. And so due to the fact that there were really no other alternatives in the space, the FDA noted back in 2016 that single-arm open-label studies were acceptable for this particular disease space. Now, to your question, Jackie, about why there's cohort A and B, it's really important to note because you'll see this in all of the trials that are in this space. They will almost always have this design of a cohort A, which is typically a patient that has a combination of papillary disease plus carcinoma in situ, or CIS, and a cohort B that only includes papillary disease. There's two reasons why this is the case. So CIS is a flat lesion. So for those of us who treat bladder cancer, if you look in the bladder, papillary disease refers to that kind of classic cauliflower-like growth that kind of tells you there's tumor there. But CIS is much more subtle. It's a red area, a red patch in the bladder, and you can't really resect CIS. You can biopsy CIS and get yourself a diagnosis, but a papillary tumor can be resected. So when we think about intravesical therapies or systemic therapies, the treatment itself for something that's papillary, the intravesical or systemic therapy is considered adjuvant therapy because the primary treatment is the resection. However, for CIS, the primary therapy ends up being what you give after the surgery. So the surgery itself is not. So it's the difference between primary versus adjuvant therapy, and the fact that CIS is a particularly high-risk entity. So there was interest in knowing, for example, do these agents work better in one cohort versus another? So that's the reason why cohort A and B exists, and it's something you'll notice over and over again in these trials.
Okay, that's very helpful. So a lot of us are familiar with this data, but ultimately patients receive pembrolizumab at standard dosing, 200 milligrams every 3 weeks, and their evaluations included cystoscopy, cytology, and CT urograms throughout that time. The primary endpoint was the rate of complete response at 3 months, which we'll share on the next page. And of course, if they had no evidence of recurrence, then they went on to receive up to 24 months of treatment with pembrolizumab. And if they had recurrence of high-risk non-muscle invasive cancer at any point or beyond that, they then came off trial. And so cohort A, and Vikram was sharing the reason that cohort A exists, but this was those who had the high-risk CIS with or without papillary disease. And what you can see is that rate of CR was 41% at 3 months, and that was in the 102 patients in this cohort. The duration of response in median was about 16.2 months. 0% of patients ended up progressing to muscle-invasive bladder cancer while they were on study. And I think a really important thing with this drug is that if we look at those who had, the 41% is those who had that CR at 3 months, but if we look at those who remain in CR at 1 year, we're looking at 19% of patients. So it really speaks to the lack of durability of this option in this space. And so also, this is a systemic agent versus some of the agents, either the intravesical chemo or some of the agents that Vikram will share with us next. And so systemic agents have systemic side effects. We're used to using pembrolizumab in many, many diseases, and we're used to seeing some of these immune-related side effects. And sometimes that's as minor as a dermatitis or thyroiditis that I can give levothyroxine for, and sometimes that's as severe as a myocarditis. So we know the gamut, we know the range there, and that this is very serious risk, particularly when someone has a very localized non-muscle invasive bladder cancer. So I try my best to explain that risk to patients when we're considering this option. I'll just briefly, I think I included the information from cohort B, which is those without CIS that either had TA or T1 disease, which we know is that lower risk population for which this is more of an adjuvant treatment rather than a primary treatment. But the point here is that ultimately the majority of patients go on to have progression of their cancer, and the durability of that response is somewhere around 7.7 months. So in January 8th of 2020, ultimately pembrolizumab was approved for those who had PCG unresponsive, high-risk, non-muscle invasive bladder cancer. They had to have CIS with or without papillary tumors, and they were the patients who refused the gold standard cystectomy or aren't eligible for it. All right, so this just speaks to the actual conversation that I would have with Gary or anyone like him in clinic. I remind him that if we are pursuing pembrolizumab, this is not an entirely non-invasive approach because he's still going to need to have regular cystoscopies to look inside his bladder, something that he doesn't like to do. It is appropriate for those who have impaired bladder function and a lot of baseline bladder symptoms versus some of the intravesical treatments require pretty good bladder function to keep that treatment in the bladder for a certain amount of time. So it is a good option if that's an issue. This is a commitment to, up to 24 months of treatment, which is not insignificant, and we know that that risk of immune-related side effects goes on the longer we're on the treatment. And I try to be as honest as I can that efficacy questions about this therapy in this space remain, and I try to bill it as this is really kicking the can down the road and delaying our need for more definitive therapy rather than, for the majority of patients, rather than representing a cure for you. And I really heavily emphasize that risk of hopefully mild but potentially severe immune-related side effects.
So the other option that was approved late last year was nadofaragene firadenovec, or adstiladrin, which is an intravesical agent and one of the first gene therapy agents that has been approved in recent times. It is a non-replicating adenovirus that combines interferon with SYN3, which is a basically kind of like a detergent. So historically, the kind of historical background on this drug is that people have tried in BCG failure patients things like intravesical chemo, but also intravesical interferon, with the thought that the kind of biology of immune-related actions of bladder cancer can basically get modulated by the addition of interferon. But if you look at a lot of the systematic trials, that have investigated the efficacy of that, the systematic reviews have shown that interferon, when just given alone, does not really move the needle much. And there is, without getting into too much of the weeds, a lot of research done in kind of understanding that. And the bladder has a glycosaminoglycan layer, or GAG layer, which basically sort of keeps the body from absorbing bacteria or other things that might otherwise cause problems. And so what SYN3 does is essentially act as a detergent to break down that glycosaminoglycan layer, such that this non-replicating adenovirus that delivers interferon can better deliver into the actual urothelial cells that are affected. So what this basically does is it kind of hijacks the cells, the bladder urothelial cells. This is a kind of a meme that has been we've hijacked to explain how nadofaragene works. But basically, adenovirus delivers the interferon alpha-2b cDNA into bladder urothelial cells, and then converts the urothelial cells into kind of an interferon-producing factory. So there ends up being kind of a local bystander immune effect, as well as a cytotoxic effect through a number of different mechanisms. So there was a phase 3, again, single-arm study that was performed. This was a completely urologist-led study sponsored by the Society of Urologic Oncology Clinical Trials Consortium. You'll notice that the study schema is basically identical to the keynote study that we just looked at, with two cohorts A and B, one with CIS patients, one without CIS patients. And the dosing of this is actually very convenient compared to, for instance, other intravesical agents, because instead of giving an induction course once a week for 6 weeks, you actually just get one dose, and that occurs every 3 months. Unique to this study was that at month 12, there was a mandatory biopsy required in all patients. So in the keynote study, efficacy was assessed visually, which is kind of standard of care. But here, every patient, regardless of whether there was evidence of visual recurrence, underwent biopsy of kind of targeted areas in the bladder. So the 3-month efficacy that was reported out in this study, which is published in Lancet Oncology, was about 53%. Now, one of the things that, and all of the patients who achieved a complete response occurred within 3 months. But when you, again, look at the durability, you once again see that just like in pembrolizumab, the complete response rate at 12 months drops off quite steeply. It's about 24% in the CIS cohort. So again, very stubborn disease process with kind of the long-term efficacy in question, even with a lot of these new agents. Here we go. So one thing that is different, though, is that the adverse event profile is, I would argue, somewhat more favorable than pembrolizumab. And this is not unsurprising because it is not a systemic agent. It's delivered intravesically. So most of the adverse events are things like dysuria, urgency, frequency. There were no grade 4 or 5 toxicities, and only 2% of patients discontinued treatment because of adverse events. So again, as I noted earlier, in late December or mid-December last year, this was also approved for BCG unresponsive high-risk non-muscle invasive bladder cancer, but is still not currently available due to manufacturing issues, and that's expected later this year to hopefully be resolved. So kind of going back to the slide that we were looking at, the gold standard treatment for BCG unresponsive disease is radical cystectomy. Valrubicin has about a 10% 1-year efficacy rate, and then pembrolizumab and nadofaragene both have kind of comparable 1-year response rates, but with very different AE profiles.
Are there any candidates who are not suitable for nadofaragene?
So yeah, that's a good question. Just like the BCG patient population, we typically don't give these intravesical agents to patients who might be immunosuppressed. So if they're on, steroids or biologics for autoimmune diseases, you typically don't, because it's kind of unknown how the non-replicating adenovirus would work in that. So that's one area. Anybody who has active hematuria, so we usually after a TURBT, you wait a few weeks to kind of let the bladder heal, again, because you don't want systemic absorption of these agents. So those are kind of the standard sort of patient populations we look at.
And we included this slide just to continue to point out that amongst our FDA-approved agents, there's a huge unmet need here because the durability is quite low if we're looking at 12 months after the initiation of treatment.
So yeah, another thing just to mention here, this slide talks about some non-FDA approved but used frequently treatments. So, we've had some issues with BCG shortage in the last few years. For those unfamiliar, there's only one manufacturer of BCG because of some issues that were raised with by the FDA with another manufacturer, leading to that manufacturer discontinuing production in North America. BCG, as you all know, probably is primarily used as a vaccination against tuberculosis. So it's sort of been hijacked for use in bladder cancer, and the majority of BCG is used actually for tuberculosis vaccination in parts of Europe and the developing world. So one of the things that often happens is patients can't get BCG, so we often give them half-dose BCG, which is logistically complicated because you have to pair patients up since once the vial is open, it can't be saved. And so something that has emerged as an option in centers that either don't have BCG, but also if they've tried BCG and they've failed, is this combination chemotherapy option where a patient will come in, get a catheter placed, and then they'll get gemcitabine instilled in the bladder, and after an hour, the bladder will be drained and docetaxel will be instilled for an hour. And so again, this is tricky in the clinic because it's a 2-hour process for our nurses, for our patients. It's once a week for 6 weeks. Interestingly, the data from this all comes from retrospective series that suggest a very high efficacy rate, and anecdotally does seem to work well. There is a trial underway, a randomized trial underway to kind of confirm this, but it has kind of emerged because of just the nature of the fact that patients don't want cystectomy, and BCG has been, has had limited availability as an option, but it is not FDA approved, and if we of course disclose that to patients before it's administered.
And so we've covered the gold standard, our FDA-approved agents, our off-label agents, and so we'll briefly, very, very briefly, talk about some of the ideas that are being put into place in clinical trials. Yeah.
Just a quick question.
Yeah.
Gemzar comes in a pretzel. So,
Stay tuned. There's more.
Gotcha.
Yeah, great question. Yeah, so, what we're kind of this next section here is basically a kind of, what do we do? How do we improve this kind of stubborn 20 to 25% complete response rate? Is there something more that we can do? So as I alluded to earlier, bladder cancer is an immunogenic tumor. And so can you potentiate the immune system with immunotherapy agents, perhaps in combination? So not really going to get into all the details because there's a lot here, but Keynote 676, which is open at Emory, looks to answer in part this question where patients can get the option of pembrolizumab with or without BCG, and this is both available for BCG unresponsive patients as well as BCG naive patients. So that study is open and ongoing. There is another kind of a gene therapy like agent that is that CG Oncology is sponsoring. That's that Core 001 study, also combined with pembrolizumab. Recently, there was a readout on the Quilt 3032 trial, which looked at NK cell type combined with BCG and actually reported out pretty good complete response rate, but unknown durability. This was presented at ASCO last year. This is the Immunity Bio product. It was not FDA approved this year when it went up for review due to some CMC issues, but is expected to be resubmitted later this year. And then to your question about the gemcitabine pretzel, that's the Janssen product called TAR-200. There are a number of different sort of spaces in bladder cancer that this is being investigated in. So what this is basically a device that can be inserted into the bladder through a catheter or cystoscopically, and then basically takes the shape of a pretzel, which is why we call it the gemcitabine pretzel, sort of colloquially, such that the patient can't void it out. It's later then extracted, usually every 3 weeks. But what it has is it's got these mini tablets within it, which have slow release gemcitabine. And so the thought is that this in the bladder will, provide sustained gemcitabine release. And some of the trials, and there's a trial in kind of the BCG unresponsive space, the non-muscle invasive kind of high-risk space. There's also the trials in cis-ineligible patients, as well as in the muscle-invasive bladder cancer space. These all, some of them combine with the Janssen version of PD-L1 inhibitor, sirtuximab. So this was presented at AUA 2023. This slide is the Sunrise 1 study, which was for patients with BCG unresponsive disease. The primary endpoint was overall CR rate. You can see there were 3 cohorts, one that included the pretzel plus sirtuximab, the pretzel alone, and sirtuximab alone. And the findings were actually quite promising. I don't know if we have a slide with that on it, but they showed a overall complete response rate for the TAR-200 device of over 70%. Again, with fairly good adverse event profile. So again, durability is still a pending question, but this is something that is relatively straightforward for urologists to do and remains a potentially emerging option. So, kind of to round out this slide here, this is kind of the landscape of what we have for BCG unresponsive patients right now. You've got your cystectomy, you've got your bladder sparing options, which have some questionable efficacy. There's one off-label option, and then there's a number of clinical trials, some of which we haven't even talked about.
So Gary ultimately opted for pembrolizumab. He did achieve a CR by 6 months. He had some pretty mild immune-related side effects, as we're used to managing. Unfortunately, he ended up having relapse disease at 13 months, and his pathology at the time of TUR showed high-grade UC, invasive into the muscle layer this time. So that brings us to our second case, which is Gary's muscle-invasive bladder cancer. So he's hearing about his options, which include the gold standard of neoadjuvant chemotherapy followed by radical cystectomy. And we're also going to talk to him about trimodality therapy, which includes maximal TURBT followed by concurrent chemoradiation. And just as before, he remains adamant about avoiding cystectomy at all costs. And so we've referred him to our friendly local radiation oncologist to talk more about those options. So Vishal, when someone is coming to you for this initial consultation, how do you think about their candidacy for bladder-preserving therapy?
Sure. So as Vikram alluded to, cystectomy is a major kind of life-altering type of intervention. So bladder preservation has gained a lot of traction. In general, candidates for bladder preservation, we kind of think about patient-specific factors, and then we think about disease-specific factors. So disease-specific factors often relate to being able to get enough radiation dose to a site to sterilize any type of disease. In general, radiation does very, very well at controlling microscopic disease. So we want patients to have a maximal TURBT so that we are indeed treating microscopic disease. In settings where patients have gross disease outside of the bladder, so T3B or T4 disease, including patients with hydronephrosis, which, as Vikram alluded to, that's often related to disease extruding out of the bladder and being T3 disease. The doses of radiation that we need to get to are much higher than can be tolerated by the bowel or by the ureter. So in general, those patients who have gross disease remaining after a TURBT are generally not great candidates for radiation. Also, patients who are unable to get radiosensitizing chemotherapy, the use of concurrent chemotherapy decreases cystectomy rates by about 30% in the BC2001 study. So in general, we want these patients to get radiosensitizing chemotherapy. For patients with extensive carcinoma in situ, again, when we think about the toxicity to the bladder as a whole and being able to give enough radiation dose, these patients often are unable to sterilize the entire bladder if they have carcinoma in situ. And then for radiation in particular, patients with Crohn's disease or other inflammatory bowel diseases have been excluded on study because of the risk of late toxicities. And then finally, patient-specific qualifications. So we want to save a bladder that is functioning well. So patients that are already getting up 5-6 times at night to urinate, we are only going to make that worse afterwards. In the BC2001 study, about half of the patients that required a cystectomy required it for bladder-related toxicity. So only half of them had disease recurrence requiring a cystectomy. The other half we would say were possibly poorly selected. And then for histologies other than urothelial carcinoma, so things like sarcomatoid components, oftentimes we are unable to get enough radiation to sterilize.
And I know that we always talk about trimodality therapy as, it includes the three of us, and the surgical component of that is the maximal TURBT. And my eyes were a little bit opened when Vikram first explained to me what defines a maximal TURBT. Can you share that with everybody?
Well, so yeah, I think there's a lot of misconception about this, but when you're trying to do a maximal TURBT, what you're really trying to do is slightly perforate the bladder to the point where you've actually kind of seen some fat. So when we do a maximal TURBT, we're actually going in and not just getting rid of all visible tumor, but taking some of that bladder wall with you. And this is why it's particularly challenging when patients have tumors located in, locations such as the dome or the trigone, which are close to the ureteral orifices, because it's notoriously difficult to do maximal TURBTs in those areas. So there's obviously safety concerns here. Patients need to understand that they'll have a catheter placed for at least a week to kind of let that bladder heal. There's obviously the risk of if you're too aggressive, you might actually perforate the bladder to the point where that could require additional surgery. But it is different from a complete TURBT, which is what we usually strive for. So a maximal TURBT is something that a urologist really has to be involved with, has to have some experience with, and has to specifically use the term maximal TURBT in their operative report. So just because you see someone has done a complete TURBT does not mean they've had a maximal TURBT.
Yeah.
So thank you for sharing that. That's interesting. So does the muscle grow back in areas where you've scraped it that far deep?
Usually it just scars down, so you don't get regeneration of muscle. You just have kind of the bladder contract over that resected area.
Does it affect bladder function also?
So, I think that's a complicated question because bladder function is partly affected also by the radiation that the patient ultimately gets. What I would say is that if you were to just do a maximal TURBT with nothing else, patients can often have issues such as urgency, frequency, decrease in bladder volume, decrease in bladder compliance. There are things you can do to fix that, but certainly, and I think Vishal will kind of talk about this a little bit. There are some, quality of life things that do come up from time to time that we help manage as well. So.
You have all the same questions I have. So when you're meeting this guy in clinic, Vishal, and you're talking to him, or her, 2/3 are men, but men or women, what are the factors about their disease? And you referenced some of them, but what are some of them, if they're a candidate equally? They meet all of everything that we think of as the ideal radiation candidate, and they're also a candidate for cisplatin-based neoadjuvant chemotherapy and radical cystectomy. What would prompt you to say, I really think we should consider chemo and surgery?
Yeah, so I think it comes down to those patient-specific factors. So one, baseline urinary function, like I mentioned. I think the other one is age. I think a lot of the side effects from radiation, you get acute side effects, and then you can also have late and chronic side effects. Things like radiation enteritis can come up 3 to 5 or plus years down the road. It is notoriously difficult to manage radiation enteritis if we are talking about kind of rectal inflammation or sigmoid inflammation. You have steroid enemas, but oftentimes we're talking about small bowel that dips down near the dome of the bladder that gets a substantial amount of radiation, and management of this is often complicated. It is oral kind of anti-inflammatories. At worst, it can be surgeries to resect parts of the bowel. So oftentimes age is one of the major factors I consider.
And you talked a bit about the short and long-term toxicities of radiation that you counsel patients on. Anything, I guess, to add to that, and specifically, because I get asked this in my clinic, and I say, you're going to have to talk to Vishal. So specifically about the impact of trimodality therapy on his sexual function.
Sure. We talked a little bit about the urinary side effects. I think there are also acute bowel toxicities, so things like diarrhea are very, very common. Late toxicity, so there will always be urinary frequency urgency. Most people are on antispasmodics long term to try to manage some of the urgency. In terms of sexual function, specifically, we do see a decrease in sexual function that tends to improve by 9 to 12 months. In long-term trials, about 60+% of patients, of men, I should say, are able to regain some degree of erectile function. The number is lower for women in terms of developing things like vaginal dryness and vaginal stenosis. Long-term satisfaction with sexual function is often under 50%. So I think we put this trial in here to talk, or this meta-analysis slide in here to reference the overall survival rates for patients treated with contemporary chemoradiation and cystectomy. The 5-year survival rates are very comparable, around 50%. 10-year survival rates also very comparable around a third of patients.
And so briefly from the systemic therapy side of things, one question that will come up is there a role for induction chemotherapy before pursuing trimodality therapy? We really don't have a clear role or good data to support this, and certainly if somebody has nodal disease outside of the bladder, you may be tempted to try some neoadjuvant chemotherapy prior to chemoradiation therapy, but ultimately in this person, there is no standard path to a radiation approach. We know that the disease is outside of the bladder, and they're really going to either need systemic therapy as their primary modality, and if they have an amazing response to systemic therapy, only then would we talk about surgical consolidation. In terms of the actual backbone to choose, this is right from NCCN, and you'll see that there's a few different options. I find it sometimes confusing to know, well, which one would I pick? And I think ultimately we choose one, we get used to it, and we use it. We understand the side effects, and that's what we use. I think a couple good things to think about are that most clinical trials that enroll patients with muscle-invasive bladder cancer into any kind of chemoradiation will allow the choice of cisplatin monotherapy, 5-FU plus mitomycin, or gemcitabine monotherapy. Those tend to be the three. I think 5-FU mitomycin is a great option for anyone who's fit, is good for 2 concurrent chemotherapies, and maybe doesn't have ideal kidney function to be able to tolerate cisplatin monotherapy. Anybody who is perhaps a bit older, a bit more frail, I'm worried about, I choose low-dose weekly gemcitabine for those patients. And over on the right was just the data of radiotherapy with or without 5-FU mitomycin, published in 2012, which led to the more widespread uptake of 5-FU mitomycin as a sensitizing regimen in this space. And so we want to talk briefly about these 3 trials because they're all open and enrolling at Winship right now. I'll have Vishal just talk a little bit about 1806 because that's run out of our radiation oncology department.
Sure, yeah, SWOG 1806. So these are node-negative muscle-invasive bladder cancer patients. They get they're randomized to concurrent chemoradiotherapy with or without atezolizumab, concurrent and adjuvant. We do a mid-treatment cystoscopy to assess disease response, and then we do a post-treatment cystoscopy as well for surveillance.
And then EA8185, or the INSPIRE trial, is run through the ECOG-ACRIN group. And so this is a phase 3 trial in which patients who have locally advanced bladder cancer that is node positive on imaging or biopsy. Previously, there was no path to radiation for them. We really said you're going to need neoadjuvant and potentially surgery. And so this is an opportunity if you have a patient who has node positive disease but is interested in a bladder sparing approach, please send them our way. So these patients are randomized to receive chemoradiation with or without durvalumab immunotherapy. And then we also have the Sunrise 2 trial.
And that study I kind of alluded to earlier, but it's for patients with low volume muscle invasive bladder cancer disease, so 3 centimeters or less. They get either the gemcitabine pretzel with sertralimab, or they're randomized to standard of care chemoradiation trimodality. I think at our institute we prefer 1806 for these patients, but we like also giving patients the ability to choose from a menu of trials, and so there are some patients who prefer the pretzel, and so that's available for them.
And so just to wrap up Gary's case and to wrap up our entire section, so he ended up undergoing trimodality therapy. He had his maximal TURBT, as Vikram defined, followed by his radiation and chemo. His GFR was 41. I didn't want to risk it, so we opted for 5-FU mitomycin as his concurrent chemo. He continues with surveillance imaging and cystoscopies, and has not had any recurrence at 2 years. And so I know that we're low on time. I had one more question, but we'll just go ahead, and if there's any questions, we're happy to take them. It was a very bladder-heavy day, but I think this is important because we have to now know this space in a way that we didn't before. So thanks for your attention, guys, and happy to take any questions.
Okay, thank you.